How's it going, everybody? Today is going to be all about Levophed, and this is Remember Your Meds, Damn It. We're going to be absolutely ripping this drug apart until you know it inside and out. No acronyms left hanging, no little vague descriptions, and you're going to know exactly what is going on with this medication, the receptors, organs, bedside knowledge. So let's get right into this. First, we're going to kind of give a broad overview of Levophed. So Levophed is norepinephrine. It is a catecholamine that hits the alpha-1 adrenergic receptors with a very high affinity. And it also hits beta-1 adrenergic receptors with kind of a moderate take. The immediate thing that is happening with Levo is it's going to tighten up that vascular smooth muscle, raise the systemic vascular resistance or the SVR, and push our MAP or mean arterial pressure above 65, hopefully. There are a couple of different ways that you can dose this medication. We're going to have weight-based dosing, and there's also flat rate dosing. Both of these are valid, both have literature on them, and both will help the MAP. So what we're going to be wanting to focus on with that first hour after starting Levo is getting a central line, starting the infusion, and possibly titrating aggressively if the MAP is still low with the patient. We're going to make sure that we're checking labs, and then beyond that, we're going to be weaning carefully because it's very fast on, fast off, evaluating for ischemia, and just really trying to treat that underlying cause of the shock, because this is not a fix for shock. It's just a Band-Aid. So now that we've gone over a little bit of the overview, we're going to do a deep dive pathophys, so buckle up. So the receptor action of Levophed or norepinephrine, it is alpha-1 adrenergic receptor, hitting the GQ protein coupled receptor, where GQ is the guanine nucleotide binding protein alpha Q subunit. Translation is the alpha-1 receptor is kind of like a panic button on the blood vessel wall for that smooth muscle. Levophed walks up and absolutely smacks the shit out of that button, and the blood vessel just starts screaming as it tightens up. This also activates phospholipase C or PLC, which kind of think of PLC as like an office intern. Once you've slapped that panic button, it's just going to come in and start shredding up paperwork. It has no idea why it's doing it. It just knows that something big is about to happen. And this splits phosphatidylinositol 4 and 5 bisphosphate or PIP2 into inositol triphosphate IP3 and diacylglycerol DAG. Translation being all that shredded up paperwork from the phospholipase C, PLC, it gets turned into new memos within the office, IP3 and DAG. One memo says release all the calcium, and the other says keep this contraction party going. One's keeping it contracted, and one is just releasing calcium. And the one that is going to be releasing the calcium is the IP3, or the inositol triphosphate. It is going to be releasing the calcium from the sarcoplasmic reticulum within the cell. Picture our office example, and the IP3 is pretty much pulling the fire alarm in the closet. Suddenly, all this calcium is going to be released all throughout the office. Water pouring down, it's the calcium pouring out, which all of this together inevitably increases smooth muscle contraction, arterial and venous vasoconstriction, and increases the SVR and also increases the MAP. All right, so that is everything within the alpha-1 adrenergic receptor. Now we're going to be talking about the second one, which is the beta-1 adrenergic receptor. This is also a GS protein coupled receptor, GS guanine nucleotide binding protein with alpha stimulatory subunit. So this activates the adenyl cyclase. Think of the adenyl cyclase as like the bartender for the cell. When the hype man screams, the bartender starts mixing up this nice special drink, which is the CAMP cocktails for everything. So this is obviously going to be increasing our cyclic AMP or the CAMP, and also activates protein kinase A. And we're going to keep the bar example rolling. So the protein kinase A, kind of think of it as like the DJ in the bar, controlling everything about the energy in the room. Once the CAMP hands the aux over to the DJ, he just starts flipping switches that get calcium channels ready to blast open, which opens opens up the L-type calcium channels in cardiac myocytes, which translation, the calcium channels are the doors to the rave or the bar. The PKA swings the doors wide open so that all the calcium can just flood in every time the heart cells depolarize, which gives you all the things that we know. Inotropy, which is the increased contractility of the heart, chronotropy, which is the increased rate of the heart, and dromotropy, which is the increased conduction velocity in the AV node. So a lot of technical, really in-depth stuff with that, but an overall translation of the alpha 1 and beta 1 receptors. The alpha 1 push with levo is the dominant push, and it's going to clamp down those blood vessels. The beta 1 effect is weaker, but it is clinically relevant. You're going to have a stronger heart squeeze, modestly faster rate, and a quicker AV conduction, which all of this together gives you tighter pipes, slightly harder pump, and an improved pressure. But also remember, overall, this is really fast on, really fast off, looking at 1 to 2 minutes on, 1 to 2 minutes off, and a continuous infusion of levo is needed in most situations. So now moving on to the dosing, and we're going to be talking a flat versus weight-based approach. So the flat dosing, which is non-weight-based, is normally anywhere from 5 to 15 micrograms per minute starting range up to 30 micrograms a minute, and you can even see 60 to 100 micrograms per minute in some refractory shock and certain situations. And then we have weight-based dosing, which is normally what I tend to see in most facilities that I've been at. And that's 0.05 to 0.1 micrograms per kilogram per minute start, which you can easily get up to 0.4 micrograms per kilogram per minute in most facilities. And in extreme cases, we can actually ride this all the way up to around the 3 to 3.3 micrograms per kilogram per minute range. But again, follow your hospital's policy. So really, when it comes to dosing, the flat dosing rate is fast and easy, doesn't require you to do any kind of calculations or any additional things. It's just locked and loaded. Weight-based dosing is more precise, scalable, and especially is really good in use for obese and pediatric patients. But either way, both of them are valid. They're both supported by literature. 2023 comparative studies show similar outcomes. The only real difference within those studies is it showed that weight-based, because it's more precise and scalable, used slightly less total drug per patient. So let's talk a little bit about some safety tips and errors and things that you see people get trapped into. So again, with the dosing thing, coming back to that, I've seen nurses and facilities try to flip-flop back and forth between this flat and weight-based dosing, and it's just asking for an issue. If your policy says micrograms per minute flat dose, but you want to do micrograms per kilogram per minute, you may end up doing tenfold overdoses on your levo. So just make sure that you follow your policy, stick to either flat or weight-based, and don't flip-flop. If you, for some reason, have a patient that is having an overdose of levo, I feel like this would be very difficult to kind of pinpoint, but you're going to see severe hypertension, arrhythmias, mesenteric ischemia, and you're obviously going to see that classic digital necrosis, which in a lot of times can happen if you're running it through a peripheral line too long, which is why we need a boost for a central, which is also why a lot of hospital systems have standardized their dosing strategy, built guardrails into the smart pumps, and enforce closed loop communication when you're ordering these kinds of drugs. So specifically, some nursing insights that you're going to want to know about this medication and things that you should be doing in the background along with the medication. So levo is well known for it being first line for septic shock. You're going to be making sure that you're giving your 30 mg per kg crystalloid or the equivalent volume resuscitation if this is septic shock. Now, there is some new literature that came out earlier this year. I'll be doing a follow-up on that actually suggests that if you're within the time frame of the 2 to 4 hours of hypotension from septic shock, that crystalloids or your fluid resuscitation should be started along with a small dose of levo for the best outcomes. But I'll dive into that in another video. When we're talking about about how we're going to be giving the medication or what we're going to be giving it through. Obviously, central line is best for any pressor, doesn't matter what it is. Central line is always best. Peripheral line is okay in the short term, especially when you have a crashing patient on the floor, especially seeing as I'm rapid response. We start levo through peripheral lines all the time, but we're being very, very cautious. We check those lines well before we're using them, making sure that there's no risk for infiltration. And if we even remotely think that that line is not good enough for a pressor to go through, we're starting another ultrasound guided IV. Also, make sure that you're checking and verifying your bag concentration. We can see a wide range of concentrations, and you need to know which one you have when you're programming it in your pump. When it comes to titration increments, normally whenever you have a flat rate, you're going to look at 2 to 5 micrograms per minute every 2 to 5 minutes. And if you're weight-based, you're going to be 0.02 micrograms per kilogram per minute every 2 to 5 minutes. So for the MAP, you're going to be wanting it greater than 65 unless it's an individualized thing for the patient. Chronic hypertension, some other issues. If the doc wants it a different way, they'll normally put an order in or at least tell you. So the big things that we're going to be monitoring, we're going to have a arterial line, hopefully. We're going to be having continuous MAP. We want a urine output goal of greater than 0.5 mLs per kilogram per hour. We want to trend down on our lactics. Obviously, if this is septic shock, we're going to be having hypotension along with it and more than likely having a decrease in mentation. So we want to see mentation improving while we're increasing and titrating this drug. And the big things to watch out for, I cannot stress this enough. There's a reason that Levophed has the bad reputation that it has. You're going to be watching fingers, toes, and gut for ischemia. So let's just bring everything back together and kind of end this on Levophed. So Levophed is an alpha-1 clamp on the vessels and a beta-1 squeeze on the heart. It works fast and it's gone fast. So this is going to be a continuous drip. There are 2 different dosing systems, like we said, flat and weight-based, but you're going to need to know which one your facility wants, pick one, and never cross streams. A big thing to remember is always protect your organs. It raises pressure, but it can starve periphery if overdone. Central line is always king, but peripheral has its place for short stints in stabilizing patients. And remember, always fix the underlying problem. This medication is a support medication. It is not a cure. So this was Levophed. It's not just another drug on the drip list. It's a pressor that makes or breaks a patient's perfusion, and every second counts. You're not just dialing up the pump. You're choosing between ischemia or survival, between pushing too hard and not pushing enough. This series that I'm doing, Remember Your Meds, Damn It, isn't just about memorizing the numbers. It's about knowing exactly what happens when you hit a receptor and know how it cascades through organs and why patients either stabilize or crash. So this was Levophed. Next time, we're going to have another med, same no-nonsense breakdown, but very in-depth. Because if you're in ICU or ER or a critical care location and we're practicing at the level that we are, you don't just get to half-ass know your drugs. You either know them or they're going to own you. So this has been Remember Your Meds, Damn It, and I'll see you guys in the next video.